Hi, everyone. My name is Samira Daswani, and I'm the host of the podcast, The Patient from Hell. I have a very, very special guest who, prior to us recording, reminded me that we probably connected about a year ago. And about a year ago, I had told her that we should have her on this podcast. So here we are, 1 year later, finally making that happen. Um, Katie has been someone who has been inspiring me from the first of my life. There are lots of inspirational stories and across the universe, but Katie's is one that I hold near and dear. So, with no further ado, Katie, thank you for being a guest on our podcast.
Thank you so much for having me. I really appreciate it. And that was a very, very kind intro.
Katie, I'd love for you to tell people how you came to be the celebrity TikTok star that you are.
It all kind of happened on accident, actually. So I started sharing um, my cancer journey or whatever we want to call it. I know people have different feelings about the phrase journey in itself, but I don't really have a better one. So it's the one I tend to default to. But I started sharing my diagnosis and the whole journey and process right when I first got diagnosed. I initially started sharing on Instagram, and I shared every single day because when I was first diagnosed, I was diagnosed at 29 years old, and I was diagnosed with a rare stage 4 kidney cancer. And at the time, I knew absolutely nothing about cancer, nothing about healthcare or just anything medically related. And so I was terrified. All I had really to go off of is like what I'd seen in the books and movies and TV shows about what stage 4 cancer looks like. And so I was petrified. And I kept hearing from other people like you can live with cancer. People live with cancer and there's so much life left to live. So I started sharing just to kind of document the process. So if anybody else came and found themselves in my shoes one day, and was also scared, maybe they could like look to my story and see what to expect. Like even basic things of like, I had never had a CT scan before, or like I didn't know what to expect for those things. And so I wanted to be able to share that to help any patients who may come behind me. And so I originally started sharing on Instagram, and I still share there. I've shared a story every single day for the last 2.5 years, which is kind of crazy to
Wow.
like go back and look back on now because they're like documenting the past. But then I started sharing right as my story kind of started to change. So I was inoperable when I was first diagnosed. I had a really large tumor on my right kidney and about 15 tumors in my liver. And the type of kidney cancer I have is super, super rare. So we weren't sure I was going to respond to treatment. And I was inoperable for the first part of my diagnosis. Um, but then I started going for second opinions and had a million second opinions. Eventually, ended up getting to the NIH, who started to offer a route to surgery. And that actually happened this time 2 years ago when I started having those discussions. And that's when I started sharing on TikTok. Um, I just kind of started sharing what that was like too, and kind of making some like quirky videos or videos to just share about what kidney cancer is like. And then just kept sharing online through TikTok, and slowly those videos accumulated. But the big one that got most of the attention would be about a year and a half after that, when I shared that I went and applied for a new job, kind of mid diagnosis. I guess I'd had the surgery at that point, but I was still technically stage 4. And I did disclose that in the interview process. And so that kind of got a lot of attention as I was taking people along. I didn't know what I was doing, but I recorded a video through that process and just kind of said, okay, for better or for worse, let's see what happens. And thankfully, it turned out pretty well. So, yeah.
That's probably one of the reasons why I think your story is so cool. I think disclosing something like that in a job interview is, it requires a lot of strength in a very, very unique way. So,
Yeah, I appreciate that. I feel like I was very, very fortunate because of the situation I was in. Like I already had a phenomenal employer. I was working part time, and was part of the reason I was working part time was I was working on my own app, and I was trying to like build resources for patients. I think that's when we kind of originally connected. Um, And so I didn't feel like I had a whole lot to lose. Like I really wanted this job, but I also more than I wanted this job, I also wanted to see what would happen. Like what happens if I'm just
Mm,
honest and share kind of where I'm at in the
mm,
process. And for me, that worked out. I know that doesn't work out for everybody. And I think my particular situation, like, also helped that because, like, I shared my diagnosis, but it also came from I was building an app for patients. And so it kind of explains why I
yeah,
was building this app. And it was all kind of tied together for me.
yeah. Can I actually go all the way back to the very beginning? How did you find, what was the trigger event that led you to starting the process of diagnosis?
Yeah, it took me about a year and a half to get a diagnosis. At first, I just been feeling kind of off and been dealing with a number of different symptoms that I was trying to track down. I had some fatigue. My biggest symptom I had is I had a rapid heart rate that I just could not get to come down. I had
Mm,
high blood pressure. And then these severe, severe lower abdominal cramps that I used to get
mm,
that they thought was either my menstrual cycle or endometriosis, but we think now that that was actually like the tumor bleeding. um, and so I was going through a workup process and kind of just wasn't getting any answers for all of these symptoms. And everybody just thought that it was anxiety. I even asked if it like we could rule out cancer at one point
mm.
because I was anxious that we didn't have answers to all
Yeah.
of these like symptoms I was feeling and was told that I was too young for cancer. And so we kind of just followed the anxiety diagnosis, which
Mm,
was kind of a self-perpetuating issue because
mm,
I had anxiety at the same time too, so it kind of just amplified that. But
mm,
eventually, I
mm,
ended up getting married, and my husband and I were building a house in a new city. And so I was going through the process of finding new doctors in that city and making sure that it'd be safe for us to have kids, kind of doing a final clear of my health. And in that process, I started to feel a hardness in my upper right abdomen. Um, and I brought it up to my new primary care doctor, who didn't really seem too concerned about it. And it just didn't sit right with me. So I ended up going to an urgent care a day or two later and showing them like the hardness that I was feeling in my abdomen as well. And they thought it could have been an enlarged liver.
mm.
They sent me to the ER, and then they immediately, as soon as they put me an ultrasound on me in the ER, they saw the tumor there. So it was a very long workup process to get to that point, but that happened on New Year's Eve 2020.
Oh man. Wow. Um, the thing that strikes me is one, the similarity between our diagnosis and then of course the dissimilarity. So the similarity piece, I'm gonna maybe start there, is I had gone in because I scuba dive, I'd come back from a trip, had gone into had a like bizarre pain in my right back that just would not kick. And I had been traveling and diving, so usually when that happens is there's kind of a protocol in place of expecting a blood clot.
Hmm.
So I had gone in and it had been a couple of weeks and it would not. And the night before I had found the alarm in my right hand and found a PCB who no family history of cancer, you're too young, not a thing. Don't worry about it. Because I was going in to get my leg imaged, he was like, look, on the off chance that you want peace of mind, I'm happy to put in an order for an image, but it's entirely up to you. You can decide. And I had actually, because the doctor was so sort of dismissive of it, I had decided not to do it. What got me was 3 hours of waiting in that waiting room to get my leg imaged. I was just like, oh my God, if I need to come back and do another 3 hours, take another 3 hours from work, I really don't want to do it. So I'm just going to go and get an image. So on the way to the technician, like, way to the ultrasound room, I told the technician, hey, by the way, I know I declined the imaging for my armpit, but do you mind just doing it? So she went back out, re-pulled the order and did it. And that, of course, triggered everything. But
Hmm.
the idea that like young women, and I call it women just because it's you and me on this podcast, get dismissed on the outset,
Yeah.
too young for cancer,
Mm-hmm.
And then you really need to end up in imaging in some way, shape, or form, have to end up in that imaging moment that becomes that confirmation. I think I've heard this now so many times, and I'm sure you have too, but I did want to underline that because I think that unfortunately it's a very common experience for a lot of people age to get that.
Yeah, I try not to like at the beginning, especially like the first day or two, I was bitter. I was like, how? Like how could like this be missed by so many people? And like it was weird. When I got my diagnosis in the ER, the doctor that was sitting back across from me, he was incredible and like I could feel the empathy as he was like delivering the news to me. He was the first doctor that ever really took me seriously, and I remember feeling like I felt relief. I was being told I had stage 4 cancer. And the fact that, like, the first emotion that hit me was relief when getting that diagnosis, like, just shows you so much of, like, all those emotions that's tied up into that when you, like, know something is wrong and you just keep being told, like, no, 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 you're crazy, you're crazy. I mean, nobody said that I'm crazy. But just that, like, that's what it felt like, right? It felt like I'm making these things up. And like for me, it had me questioning like my pain tolerance. I was like, these do not feel like menstrual cramps. Like, am I just a wimp here? Like, what is going on here? Um, and so like right after I got diagnosed, I was a little bitter because I was like, how did this happen? Like, I felt forgotten about. Now that I understand a little bit more of how like the system works, I understand how it can happen. I still think that there's major improvements that we need to do to make sure it doesn't happen.
Yeah.
Um, but it kind of got rid of those like I don't blame any of the physicians for how that happened. I do hope that they now like use my case as a way to like look out for things and remember me when they are in those situations in the future and go through scans. But I actually had something that came up with this literally just this week with my husband that made me think of this. He went to um, the doctor for some like lower back pain that he's been having, and he texted me as he was leaving and he was like, "Yeah, I got a bunch of tests and a x-ray scheduled that's down the street for um later this afternoon." And he just like went straight over and got all these tests done. And the way he was describing this back pain to me was like a 2 out of a 10 kind of
Mm.
pain level, and it was more on the mild scale for him. And I like
Yeah.
it was a really weird moment and he felt the exact same way of I was very, very grateful he was getting like very thorough follow up and making sure that we get everything checked out for him. But then we both had this feeling of like, if I were to go in and present with that exact same thing, it would take me months to get the same amount of testing done.
Yeah.
Um, and so, like, I think that it is a very real thing
Mm.
that women and just people
Mm.
can deal with in general. That there's a lot of room for improvement there.
I really like a diplomatic answer. I think I would have been a little bit more enraged than you probably were.
Yeah.
So I appreciate you being so thoughtful. I definitely resort to anger.
Yeah, it was a like I just highlight so much of that because like I spend so much time because I don't want my story to like have people have distrust in their physicians because at the end of the day like I don't think having distrust in physicians is how we solve the problem. I think like it's communication, it's education, and it's like making sure that um we highlight these experiences, but not in a way that like tears down physicians or anything like that. And so I've been so like I advocate for that so much, and I don't want my story
Mm.
to be attached to that in a negative way.
Mm.
But then when things like this came up, or like this week with my husband, it's one of those like, oh, man, but seriously, there is a very big gap here in care sometimes.
We should talk about this. This is super fascinating. I definitely did not expect us to go down this specific path in prepping for the conversation, but I think it's actually one that's incredibly pertinent. Um, and this podcast is called "The Patient from Hell." Right. So this podcast, myself, I'm a huge, huge advocate for people advocating for what their values, what they need, even if it deviates from clinical guidelines, if it deviates from what is quote unquote recommended, if it deviates from what your main clinician is saying to you, etc. Right? So I mean, I'm clearly on that side of the house. But I think there's something that you just said that was very important for us to underline, which is advocating for yourself doesn't mean that you necessarily distrust your clinician.
Yeah. Hmm.
But unfortunately, and I'd love your take on this, unfortunately, my experience has been there is such a massive power dynamic between the clinician and you, the patient,
Hmm.
that no matter what you do, it somehow comes across as distrust. Right.
Yeah.
So I can give you a small example. Actually, maybe I have way too many examples of this for what it's worth, but I'm breast cancer supposed to be standard of care recommends 10 years on hormone therapy.
Hmm.
And I declined first line because I was having really bad reactions to it. So went to second line. Second line, there's a bunch of dosaging on there, so we started on a dose of one. I was having reactions to it, so we dropped it to having bad reactions to that. And the oncologist was like, "There's no way I'm dropping this. This is this is the max. You've just got to quote unquote tolerate it." And I remember being like, "Well, I understand that there isn't current data on dropping it by another 50%, but I'd imagine that they're working on it on a trial, not in my area." And I was like, "Yeah, they're working on it. So like, why not experimentally try that?" And the clinician, again, no fault of their own. That's how we practice medicine in the US. I fully understand that we need published, validated, randomized clinical trial data for a clinician to recommend. I get that. I also know that off-label use is very common in cancer.
Hmm.
That's true as well. Both those things I said are simultaneously true.
Hmm.
So we go through this pathway, and I was like, well, I would like to try it at the second reduction of dose, and the answer was absolutely not. A year and a half later, the study is published that the lowest dose is as effective as a max dose that has been in market for the last 20 years.
Of course.
Of course, right? Of course. And you're like, oh my God, come on, guys, come
Mhm.
on. And so I'm just curious, like, where do you sit on that side of the house? How have you managed to like navigate that? I'd imagine that stage four rare cancer, you probably have had many, many encounters like the one I'm describing.
Yeah. It I don't know. I think this even goes to, so I recently did a Twitter poll on people asking for second opinions and like um, how, like, does that hurt the physician's feeling? Like, do they take it personal? I guess is actually what the poll was, because I felt like it was personal. Like it was never intended to be personal ever whenever I was like going to get second opinions. But because of that power dynamic, and every single time I've gotten a second opinion, I really struggled with it. And like I struggled because I thought that they were going to take it personally, when it wasn't about taking it personally. It was about the fact that like
Yeah.
I just need other options to know that like oftentimes it wasn't even always like I don't trust your opinion. Most of the time it wasn't I don't trust your opinion. Most of the time it was I need to feel confident by getting these other opinions to also know that this is the right opinion. And so but I've definitely sensed that in some appointments. I will say though that I've also been very fortunate, that because what I have is so rare, I end up with a lot of doctors on the other side of me that will just straight up tell me like, "Yeah, I don't know." And like I've
Yeah.
had many tell me that say like, "I don't know." And ever if anybody tells you that they do know, like you should be very wary of that because they're just making it up. Which is very true in my case because like the type of cancer I
Mm.
have is like single digits worldwide in history. So if anybody kind of makes a prediction, like it is a best guess. And I've
Mm.
sat in a room and had appointments where the physician on the other side of me very much is like pretending to like they don't I think it's tough because I think on one hand they don't want you to lose confidence in them. So I've been in the appointment where they won't tell me how rare what I
Yeah.
have is because they don't want me to lose
Mm.
confidence in their ability to treat it. I think that kind of happened like very, very early in my
Mm-hmm.
diagnosis. Um, but yeah, I don't know. It's such a tough dynamic. And I will say that I lose trust when like I don't get the I don't know, or like even like in your scenario, if a physician is like, I just don't have the data backed up, like I understand that other people prescribe out of the protocol. I just am not comfortable doing that myself. Cause that to me is like you're
Agreed.
gonna build a whole lot of trust with me
Agreed.
that way because you're not saying like it's impossible.
Yes.
You're
Agreed.
letting me know where your comfort zone is,
Yes.
which is like I think totally understandable. Um, so yeah, I had a very similar experience one time where I was going through the diagnostic process, and like the type mine is most similar to is chromophobe kidney cancer, and so everybody thought I had chromophobe kidney cancer at the beginning, or it was like kind of back and forth on it. And I sat in a second opinion one time, and it was at a new institution. And I asked them in that appointment because I kind of educated myself on kind of what my pathology was saying and kind of what the two different entities were. And I asked in that appointment, I was like, could this be chromophobe kidney cancer? And the response I got was, no, absolutely not. This is definitely not chromophobe kidney cancer. But then my next appointment was, we think this is chromophobe kidney cancer. It ultimately did not end up being chromophobe kidney cancer. But it is one of those like I think
Mm-hmm.
that's where like drawing a hard line really can um, be tough. But at the same time, I also understand that like as a patient, hearing I don't know is oftentimes very, very difficult to hear as well too. So I don't know that I have
I'd
all
love,
the
yeah.
answers to that.
No, it actually, I think it really does. And I think it opens up kind of another area that we should be talking about, right? Which is grappling with uncertainty. Because I think it all comes down to grappling with uncertainty, both on our end and the clinician's end,
Yeah. Hmm.
right? Because I think there's uncertainty in the rare cancer setting where we just simply do not have the data. We have no idea. It's kind of this moment of like, we we can only do experiments, right? You're kind of in this default mode of case studies, low and low digit patients across the like globe, where you don't have a reference point that is validated in the way the clinical trials are usually validated. Right?
Hmm.
And then you have cases like early stage breast cancer where there are plenty of women who have, some men who have lots of data, really complex decisions. And decision making in this universe looks and feels very different than a rare cancer setting.
Yeah.
And yet you sort of have this grappling of uncertainty on a different dimension, which is when do you deviate from standard of care? When do you deviate from guidelines? When does patient preference kick in?
Hmm.
What is the quality of life a patient wants for their life? What is the risk adjustment? And a lot of that burden actually starts to move onto the patient because from a clinician perspective, there's an algorithm. There's
Hmm.
absolutely an algorithm, right? And if Samira shows up or if someone else shows up, there's an algorithm. You get put in a box, and it's like, Samira, if you belong to this box, here's the algorithm that goes along with that box.
Hmm.
Right? So then the onus falls on the patient to push back on it and be like, no, actually, this part of the algorithm doesn't apply to me, or I don't want that part of the algorithm, right? So it's a funny balance of where does that like uncertainty lie
Hmm.
for the patient and for the clinician? And I'd love your take on that because I'd imagine that you are grappling with it constantly.
Yeah. I still live in a whole world of uncertainty. But I think that kind of goes to like that interaction that I was just describing of like when I came to the physician and was like, could I have chromophobe kidney cancer? And they were like, no. And then it was yes. Is like the dynamic was us literally trying to do that, right? So like I was trying to put myself into a box because I was like,
Mm-hmm.
this box over here doesn't have a treatment plan, but this box has one. So, like, do I fit in that box? And then I think the same thing happened on the other side because, like, we were trying to figure out, like, can we get me into clinical trials and those kinds of things? And so, like, as we were waiting for my pathology to come back, and like, it could have gone either way. We weren't really sure which
Yeah.
box I was going to fall into, and so that dynamic literally just shifted between us, like trying to pick these boxes essentially. Um, And so for me, once my pathology finally came back, it showed that I had a metastatic oncocytoma. And oncocytomas are typically known to be benign. Mine just didn't catch the memo and went to my liver, which is what made me stage 4. And so the there's no treatment regimen for a metastatic oncocytoma. It just doesn't exist. And so we are trying to apply it to like the closest thing to me, which is chromophobe kidney cancer,
Mm-hmm.
which is also a rare type of kidney cancer, not nearly as rare as mine, but about 5% of patients. Um, and but that group of patients are also the patients that oftentimes don't respond to some of like the normal treatments for kidney cancer now, like immunotherapy. They can respond, but just much less frequently.
Mm-hmm.
And so we were trying to fit me into a box for starting treatment that matched like a chromophobe kidney cancer plan. And so I started on a targeted treatment, which we had no idea if I was going to respond to. So there's a whole lot of uncertainty of like, is this going to work? I don't know. I guess we'll find out. And thankfully, like that treatment, actually, I did have a response to. I wouldn't have ever had a complete response, I don't think. I just had way um, too many tumors and too large of tumors. But we were on that treatment plan. And then, like, it kind of goes back to what you were talking about, like the patient preferences and when do you deviate from that plan? Because even though there's not set guidelines for me, like there's set guidelines for kidney cancer in general. And so where do we fall out of those guidelines? And my treatment very much did fall out of those guidelines. I still have not found any reports. I'm sure they exist out there somewhere, but the surgery that we did for me was very invasive, and they typically like don't operate to that level that they did in my liver. So I had 15 to 20 tumors in my liver. I still have a few spots that we're watching that haven't grown, so hopefully they're not cancer. But um, I had so many tumors in my liver, including large ones. Like my largest one was about like 5.5 centimeters, I believe. That normally, when you have that extent of disease in your liver, most of the time they won't operate. And they won't do ablations oftentimes when there's that many tumors. And so my treatment plan was way off of the standard of care. But I went to the National Cancer Institute, and they basically have the ability to try things out of the standard of care because they are a research hospital. And they'd seen some of the only other cases like mine of metastatic oncocytoma decades prior. And so they felt like maybe this thing like somehow got in my liver. And if we could get it out of my liver, it's possible that it could not go anywhere else. Again, that's literally just everybody's best guess, and nobody has a clue really. But that was the treatment plan we decided to go ahead on. And so for me as a patient, I had to decide which route I wanted to take. Do I want to continue with this treatment that it actually was working for me and I was responding to it? Do I want to stick with kind of the standard of care? Or do I want to take a risk on this surgery, which would have been with curative intent? And so there's a much bigger reward with that one, but obviously much, much higher risk. Because there was a whole lot of have a bleeding disorder as well too, and so operating on like really vascular organs was a pretty high risk surgery for us to undertake that. So I definitely agree. I think that's where rapport really, really comes into play with your physician is being able to sit across from your doctor and have those conversations to let them know like these are my goals and I understand these are the options. Like where should we fall in between there, and making that decision with them versus having to do it alone or them making it for you.
So let's maybe talk about that, if you don't mind, with the example you did. So how exactly did you pick your cut? How did you get to, I want to do the surgery?
Yeah, so I actually almost backed out of the surgery literally the night before. It that's how uncertain I was for it.
Mm,
Because there like we didn't have any guidelines to go off
Mm.
of. I didn't know that this would be successful. And pretty much in any other cancer, everything showed that this would not be successful. And so um, it was a tough decision for me. And I actually remember this is why I love the NIH and the NCI so much. I feel like there's not enough that is talked about them from like patient perspectives because they don't have like all the flashy marketing that all the other cancer centers have. But it's such a different environment there. I went to go for labs, and I was like having a breakdown. I was like, panic attack. I don't know if I should be doing this. They were trying to do, like, we were drawing like 30 tubes of blood for me
Oh,
to make sure that, like, figure out what my bleeding disorder was, if we even could go through with surgery, because there was a blood shortage and like it was just super overwhelming. And I remember texting one of the hematologists, and they were like, it was one of the fellows, and she was like, okay, me and the attending, like, we're just upstairs, we're gonna come down and talk to you. So they came down like as I was waiting to get labs collected and like just talk to me like in the waiting room to like help bring me
wow.
comfort or like answer any questions that I
Mm.
had, just from a like um, general perspective.
Mm-hmm.
And then when I started to ask like more specific questions, they were like, "Well, let's find a room, and like let's have a conversation and make sure that you're comfortable with this." And in that conversation, I ended up asking them. I said, like, I'm really scared. Everybody that I talk to keeps telling me how much they're preparing for the surgery and how big it is and how like they normally don't prepare to this level, because it was like a very, very
Yeah.
large surgery there. And I asked them like, what's the outcome? Like what is my risk level here? It sounds like it's a
Yeah.
lot bigger than I was initially expecting. And so I'm worried if the risk, like I told them, if the risk is high that I'm going to go into that operating room and die tomorrow, I don't like, what am I comparing that against versus like
Yeah.
if I just have 6 months to let this disease kind of take whatever route it's going to take.
Mm.
I didn't know what the decision was there. Um, and nobody could really provide me that answer. Like
Mm.
we had some general idea of like what the risks were going to be, but obviously nobody knew what would happen if I didn't get this cancer, this surgery. But the answer was essentially like, this is my one shot at surgery. If my tumors grow anymore, like surgery wouldn't really be an option anymore. And
Mm.
so I ended up taking the risk because it was like my only chance for a cure, essentially.
That is incredibly poignant. I can imagine you think back to that day, and it. I don't think I can imagine what it means to think back to that day. To be completely honest with you, because I don't think I've done anything remotely close to that. But I imagine that it took a lot in your end. And honestly, on your clinician's end too, because
Yeah, I like I
mm.
love all my doctors so much, and I really, really appreciate them. And so much of that is because of how transparent they are with me, and how transparent they are with me when they don't know. Like those conversations, part of what made those conversations so hard was that they did
Mm.
not know. Um, and so all I had to go off
Mm.
of was my confidence in them being able to execute the surgery, like being able to keep me alive in the
Yeah.
ER, and, or not in the ER, in the OR, and afterwards. And
Yeah.
so it like built a lot of trust for me in them. And I think that goes a long way too, because I will
Yeah.
say, like, I never felt courageous in those moments at all. Like there was a whole lot of tears. There was no courage. I was literally just doing it scared,
Yeah.
because the alternative to me was, I mean, death,
Yeah.
honestly. Like
Yeah.
I I hate to be that blunt about it, but that's like
Mm-hmm.
what my outcome would have been, just
Mm-hmm.
letting the disease take
Yeah.
its course.
Yeah, no, no, I don't think you should hate being blunt. I think that's the whole point of this podcast, to be honest, is to talk about the things that people want to talk about. So
Yeah.
I'm glad you are transparent you've been fortunate enough to have physicians who are also transparent.
Yeah.
And I also, by the way, completely empathize and relate to you not thinking you're courageous in that moment. Anytime someone says that to me, and I don't know why I said that to you right now, but it does strike me as courageous because I don't know if I could have pulled that. And I pride myself on being a very analytical, data-driven person, but you put me in a super ambiguous situation with no data. Ooh, no, I don't know. I think all of my wheels will come off the wagon.
See, but that's what, like, I think that's what's so crazy. And I think this applies to anybody at any stage in cancer, right? Because like everybody gets that label, I feel like, after they've gone through cancer of like, you're so strong. Um, and I think it's because like people just like, unless you're in that situation, like most of the time you just like you'll figure it out. Like you have no alternatives. And so that is a great motivator sometimes. But yeah, I mean, I definitely I mean, it was I'm sure my doctors hated me in that I actually have this like little tub that I created for my doctors and nurses
Oh,
that says like I know it doesn't like it right now, but I sure do love a good joke. And it had these like little candies and dad jokes on them
oh,
for them to take as I was in the hospital because I am that patient that I'm sure they don't like. I'm the one that like asks a million questions and they didn't have these answers, right? And I'm like, "Well, what's like the data or like what do you think like where's my outcome going to be or like I literally had a
yeah,
call with one of the doctors actually this week for something else and like he was expressing to me like that he's very grateful that I'm doing as well as I am and like in part of that conversation it came out of like yeah I mean like we didn't like how much uncertainty that there was and like he was acknowledging that on his end too and just like how grateful we are to be where we are now but that we did make those decisions based
yeah,
on like I mean obviously they clinically thought this was going to work or they would not have gone through with it but that there was especially externally
mm,
like nobody else was willing to do this surgery.
mm. I have a funny story for you, Katie. And hopefully it'll make you feel a little bit better about you being that patient in that room. I clearly am too in the same time. With the prior to me entering a visit room, I can see visually the oncologist like, oh shit. I think I had one oncologist who had that reaction with me. She was very nice about it. Like, no, you're a very sweet person. I'm like, yeah, I know, but I can see the separation going through your head. But the funny story is my diagnosing oncologist and my treating oncologist were not the same. So my diagnosis, and I didn't know it at the time, but the oncologist that took my case was retired and wonderful, wonderful human being who just I owe my life to him, and I truly just absolutely phenomenal human being who totally knew how to handle me from the get. So I never realized a lot of the kind of like, oh my God, I'm terrifying. My therapy came much later in my cancer experience. The first, second meeting or third meeting with him, uh, he had given me. So the clinicians often have access to the data that they can read the summaries. So
Yeah.
he had like printed it out and given it to me. So he had given me this like stack of papers, being like, look, you're gonna ask me questions. I might as well give you the data to go read. So you can go read. So he had given me the full set. And this was a guideline summarized for them with like reference papers and all the clinical trials, etc. So of course I'd gone and read everything and shown up with a laundry list of questions. And so I think one of my questions to him was, so I had triple positive breast cancer, which meant that I would be getting all modalities of treatment. So I got chemo, radiation surgery, a year of Herceptin, and then 10 years of hormone therapy, which is standard care. And we were going back and forth on whether or not I really didn't want chemo. I was okay with everything else. I was like, I do not want chemotherapy. I just don't. So I was trying every single alternative path to figure out how I could not get chemo. So one of my crazy ideas was, hey, why not start me with endocrine therapy? But if you are a female and you're above a certain age, like 70, 80, in some cases they'll actually start you with endocrine therapy for some period of time to see the tumor shrinks. and then they'll do surgery because then they know that you're responding to oral meds. And so I was advocating for this, and he goes, Samira, you're not 80. I do not have you go down this pathway with some other harebrained idea, but he was very patient and like walking me through it. So, and then 2 hours later, after me exploring all of these options, I go to the restroom, and he's standing outside with my partner. And I walk out, and I overhear them talking about me, and this is in the corridor. And he goes, some patients are very difficult. They make the most entertaining visits for me. they just mind their own. I was like, thank you. I take that as a compliment that you find me endearing, but
I'm glad that he used the term like entertaining. Is that what he said? Yeah. I don't feel like I it's funny, like I love my physicians, but I tell my husband every time after I have an appointment, and I know they don't hate me, but every time I say like, "Do you think they hate me?" Because
yeah,
like I am the one with a million questions. And I feel like that's just got to be obnoxious.
yeah, exactly. No. And at some point, I just became okay with that. I was like, oh, yeah, too bad. It's
Yeah. I mean,
gonna be what it's gonna be.
I think it goes to like advocating for yourself. Like you have to ask those questions if you're going to advocate for yourself. So yeah, I mean, I still ask all the questions. I'll still afterwards be like, man, I don't want to be on the other side of those questions, but I will still ask them because they're important.
I'm totally with you. I'm fully with you. I'm looking at the clock and I'm realizing we're at the point where we should probably start to wrap up our episode. So I usually summarize and synthesize episodes. Today I'm just going to do something a little bit different. I'm just going to ask you to share any parting guidance, advice for survivors, patients, anybody on a cancer journey that you might.
Yeah, I would say like the biggest of advice that I would give to other patients is probably literally what we were just talking about asking questions. Like ask questions and advocate for yourself, because of everything that we've talked about here. Like nothing is for more common types of cancers, there are more options and there's more guidelines to follow. But especially the further down the treatment line you get and the more rare type of cancer you have, the more that becomes a discussion with your physicians and understanding your care. And so, learning as much about your disease as you can, and then advocating and asking questions. And you have to ask questions to learn. So, like definitely I say I worry that I ask too many questions, but I think it's really, really important that patients do that at the same time. So I definitely would give that advice to any patients.
Oh, I love it. Well, thank you for being a guest on our podcast. And audience, I promise I didn't plant any of this. Katie volunteered that parting statement of her own accord, but clearly I fell into the same camp and would completely second that advice. So thank you for being a guest on our podcast. We love what you do with your time. Keep doing your TikTok videos and your Instagram videos. They're super cool. And we super appreciate you sharing every aspect of your journey. So it makes a big difference to us.
Yeah, thank you for having me. I really appreciate it.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The content here is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions.